Today is Universal Health Coverage Day. It's being celebrated around the world. And we're here to discuss um, where palliative care fits into the ideals of universal health coverage. Joining me today are four of my colleagues, good friends of Pallium India and all of us. There's Dr. Rajam Iyer, who is a pulmonologist and a palliative care physician. She works with the Bhatia Hospital as well as the Hinduja Hospital in Bombay. We have Dr. Roop Gursahani, who is a consulting neurologist with Hinduja Hospital and is also the co-founder of Elicit, which is the End of Life Care in India task force, and has been a leading advocate for appropriate end of life care in our country. We also have Ashla. Ashla is a trustee at Pallium India, and she is also a strong advocate for people living with disabilities. She herself is a care recipient as well as a care provider and will give us some unique insights into what universal health coverage looks like for, uh, for people living with disabilities. And finally, we have my friend Sahni, who is a public health specialist and has worked across the country with various sectors of healthcare and is now deeply involved with palliative care. So thank you all for joining us. To begin, I'm not going to waste any time in inviting Dr. Roop Gursahani to please take us through the evolution of universal health coverage, where it came from, what was the idea behind universal health coverage as it evolved, and what role does it play in the political economy of a country? So, Roop, that's a pretty big question to start off with, but I think you'll help us set the stage for our discussion today.
Thank you. Can you hear me clearly? Hello?
Yes, we can hear you.
Okay. Thanks, Smriti, Dr. Rajgopal, Harsh, for involving me in this very interesting topic. Now, actually, you forgot there was one more point you wanted me to talk about, which was equity, which means not shares, but the quality of being fair and impartial. And uh, how equitable is a country's health system? So, actually, let me turn it around by giving you two examples from, we call it the richest 0.1% of the population in two countries, Switzerland and India. Switzerland has universal healthcare. So, 4 years ago, an elderly gentleman of Indian origin was alone in his chalet or mansion in Geneva on a Sunday afternoon and felt acutely unwell. He called emergency medical services. The ambulance landed up in 5 minutes, took him off to emergency. He went through multiple tests. In 3 hours, they found nothing wrong and dropped him back home just as his family returned. One of the richest people in the world used public healthcare. Another slightly funny story, an 84-year-old Sindhi lady with early dementia got a bypass surgery in a corporate hospital in Mumbai. And as any neurologist would tell you, she did not wake up post-op. 1 week later, she was still on the ventilator. And as always, cardiology parachuted out saying the neurologist will wake her up. And there was no mention of ending her suffering gracefully. My friend, the neurologist looking after her, finally called her sons in and asked why they were making the old lady suffer. You know what one of them said? My mother is a very wealthy lady, worth about 8 crores. If she were to pass away and the hospital bill was not even 20 or 30 lakhs, what would people say? So in India, we have equity in suffering, whether you're rich or poor, disastrous end of life care, and horrible suffering is promised to all, unless you're a poor man living in a village in Kerala, in which case you do well. So one of my friends quipped, a corporate hospital is one in which the poor cannot enter and the rich cannot leave. But to come back to palliative care, this circles us back to today's theme. Palliative care actually is an inexpensive way of making sure that nobody, rich or poor, suffers a miserable death. So actually a bridge to universal healthcare. Now, how did universal healthcare happen? There are a couple of insights that most people wouldn't be aware of. One is that most individuals, if you ask them, do not think of uh, healthcare as being an entitlement. That's something that governments are supposed to do for you. The average voter doesn't think that the government needs to give you healthcare. If you fall in individually, you're bad luck, right? So because they don't hold politicians' feet to the fire, Politicians are not bothered about giving them universal health care. The other thing is that wherever universal healthcare evolved, because because it actually needs to be top down, it has to be an enlightened politician or a group of politicians, bureaucrats who push it through. And the first guy who did that was Bismarck in Prussia before it became Germany, long ago. And then it was just after the Second World War where the United Kingdom finally did it with the bullet, nationalized all doctors. All doctors suddenly became government servants, right? And then other countries followed until most of the wealthy countries finally got universal healthcare. And the universal healthcare is of, as it has evolved, is of really of three types. One is the single payer model where the government provides free healthcare paid for by the central government, and it's called after the politician bureaucrat who did it, the beverage model in the UK. Um, and all of these have their advantages and disadvantages. The social health insurance requires everybody to buy insurance. This then goes into a government-run fund that covers everybody, and private doctors and hospitals provide the services. But the government regulators run it fairly tightly, and Germany uses this system. Also works well. And then national health insurance uses a single insurance plan, which is largely government owned and run. And Canada does this. So if you see this, you can see that as India evolves further, as well, perhaps Achhe come along our way, we will have to evolve to one of these three models. But like the United States, we'll have to accept that it will be contentious. I do not think a voter in Kerala is going to be very happy paying for uh, a patient who comes from Bihar for treatment. And uh, all these kinds of disparities, regional disparities, and all these will need to be ironed out. And because, as I said, politicians' feet are not held to the fire on this point. Well, it's a complicated thing that they're just avoiding, and which is where I think it's important for us to push the idea that palliative care, being the least expensive part of healthcare, the least expensive modern specialty, is probably it's low hanging fruit. It's probably where universal healthcare can start in a country as diverse, as poor, as politically mixed up as India is, as contentious as India is. Well, that's where I think most of us will agree. I'm going to stop at this point and hand over back to Smriti.
Thank you, Roop. You've actually unpacked quite a bit in a few minutes. And just to sort of circle back to the fact that you talked about equity and that phrase, equity in suffering, I think that's hit me quite hard. Um, but when we talk about universal health coverage, what is the basic idea behind universal health coverage? I'm sure a lot of people in the audience are very familiar, but for those who are not, um, universal health coverage talks about access to appropriate healthcare at an affordable cost that will not financially devastate the family. So it talks about access, it talks about affordability, and it talks about not and availability as well. But what you really brought in today was the idea of accountability. Now, accountability by the decision makers, by policymakers, by the healthcare system. And what I understood from what you said is that that sort of accountability is currently lacking. And while we work towards it, then in the meanwhile, we find that the principles of palliative care do actually prescribe a lot of what we've been talking about. Let me just come back to one point where when we think about access and affordability, very often our minds go straight to people who are underprivileged, underserved, people who can't afford healthcare. Like your quote, that hospitals are fortresses that keep the poor out and the rich in. But what has been your experience working in a tertiary care hospital in a large city? Do you find that this sort of inequity is only meted out to the very poor, or what do you see happening amongst the affluent?
So
You
the
started off by
affluent.
talking about the patient. Yeah.
You want
Please
me
go
to
ahead.
answer?
Yes, please.
So if you look at it, for the very for the people who can afford it, and like that Sindhi lady spoke about, money is not the issue. And finally, I mean, if you look at it, healthcare in India, uh, even private healthcare, is not truly expensive. I mean, if you are very wealthy, then in terms of your ability to afford it, no, it's not. And India literally provides care. I mean, if you look at the technical aspect of care, we are just behind the leading edge. In almost any respect, we provide care that is maybe a couple of years behind the most advanced economies. I mean, if it is something that is profitable, before you know it, it will be introduced in India at a cost which is substantially less. I mean, you should understand that if you compare healthcare costs in the US and in India, what we pay in rupees, they pay in dollars. Remember the exchange rate. Okay, it's not so with Europe, but that's largely true across the board. So for many people who are well off, getting medically treated in India is not a problem, except in one area where, as I said again, palliative care is completely missing. So whether you're rich or poor, it just doesn't matter. What about as you go down the income scale? You know that 80% of care is provided by private services, and as you go down the scale, it it really starts being a major burden on people to the point that there's at least one paper which, for instance, has looked at for oncology, for instance, and it shows how oncology costs have climbed over the years, and now being diagnosed with cancer and having to do chemotherapy, there's a good chance that a poor family will end up with debts and a dead body at the end of it, right? So, I mean, I hope there are no oncologists in the audience, but when I read that paper, I realized why the biggest, shiniest cars earlier used to be the cardiothoracic surgeons, and now they're the oncologists. I'll end there before I say anything more offensive.
Thank you, Roop. So we brought in we've brought in aspects of access, affordability, appropriateness, and also accountability. So there's a lot of A's there. So I'm just going to move across to Ashla. And Ashla, as somebody who has experience, lived experience of being a recipient of this healthcare system, and and now you are providing care as well. You're a care provider. You bring a very unique perspective to this conversation. And what I'd like to ask you, Ashla, is specifically to do with the A of access. What has accessibility meant to you in terms of being able to not just seek out, but also get appropriate care for yourself? Can you tell us a little bit about your journey and what access has come to mean to you? You're on mute, Ashla.
Thank you, Smriti. Hi, everyone. I met with an accident 10 years back and I got a spinal cord injury. So now I have quadriplegia and I use a wheelchair for my mobility. So I need regular medical care to continue living. So I need a catheter change every month. I need continuous skin care, etc. So I was hospitalized for 10 years and before I moved to Palliative, India 6 years back. So what I got there was like, I have that experience of private hospital, staying in private hospital for as long as 4 years. And then my spinal cord injury got some attention. And then I was treated as a patient and my mother was always a bystander. She never had a name. She never sits. She's a bystander. So access to care for me at that point of time, I did not know anything about palliative care, and then I came to Palliative India. The first difference I noticed was like I was treated as a person, and more than my spinal cord injury or my disability or my wheelchair, people saw me as Ashla, called me as Ashla, and then my mother was asked for her name. She was asked for like what is it to take care of a daughter who is like 32-year-old and having is dependent on her for all her daily activities, and then what kind of a help she needs to take care of me, and then what are the issues she herself has, any medical issues. So and so that opened the whole world to me and showed me that okay, this is something which is available over there, and I never had access to it for 4 years. So, and it is still there. Palliative care is a specialty, and it is still there. And but many of the people have do not have access to it. So that is one point for me. That access to me, I also access to care is access to appropriate care for me, and which is not actually destroying my family financially, because I was totally worried about that one thing, that having my mom to sell off all her properties to take care of me. So I didn't want that, and that is where we had to actually search out for some places wherein I could get the care which I required. So that took me 4 years. So I didn't want that. So that is appropriate care, which is not financially destroying my family, and which is something like I stay out of. Like I stay here in Palliative, India, in Trivandrum, and I was born and brought up in Kannur, in a rural, very rural village, and I could never go back. But then we see a lot of patients here in Trivandrum, and Vishnu or Arun, if you could show me that picture. I just wanted to share one picture with you to show that what kind of people or in which terrain we take care of people. So this is the kind of place wherein spinal cord injured person in Kerala, if there is one spinal cord injured person in Kerala, lives in a place like this, monthly catheter change for him or her could be so devastating process, like carrying that person from home till the road, getting onto an ambulance, and then getting into the hospital and paying the casualty charges to get this catheter changed. And what if there is only just an elderly mother? Like for me, in my case, if I had gone back to my home, I would only have my mother, and who else will support me to get this care? I would have died there without getting this kind of a care. So it is for me, Smriti. When you talk about accessibility, for me it is accessibility in terms of like I should be able to afford the care. I should I should know that there is some kind of a care available over there, and finally to access it in a way, it is in a proper way wherever I'll be able to get it where I am, where I stay, and where I like live. I should be able to get that kind of a care there, Smriti. Maybe you can stop sharing screen.
Thank you, Ashla. Thank you. Thanks, Ashla. You raised a very important point also, that something can be available, but it may not necessarily be accessible. Right? And I think that's something all of us need to think about, that the services might exist, the technology might exist, but not everybody has access to it. And one of the major barriers to access is affordability. There is a 2017 report that talks about 55 million Indians being pushed below the poverty line because of healthcare expenses. Every day there are new cutting edge interventions coming out or medicines coming out. But how many people have access to these services, to these interventions, to these medicines? And that is something that we need to think about strongly. How do we bridge that gap from availability to accessibility? I just want to circle back to Roop for a moment, because Roop is leaving the meeting a little bit earlier. Roop, again, another A. Just listening to Ashla and also some of the things that were triggered for me is the idea of autonomy, right? Now, even if we have access to a healthcare system that gives us what we need, there is still the question of who makes the decisions. Now, in Ashla's case, Ashla, I mean, I'm going to just sort of say this. There is a strong element of shared decision making. Ashla is part of the unit that makes the decision for her care, and we'll come back to that in a little bit. But I'd really like Roop to share some insights on what autonomy means, especially in the case of, say, you're a neurologist. In the case of a person who has certain neurological deficits, in the case of someone who's more than 50% dependent on others for their care. So how does autonomy figure in the idea of universal health coverage?
That is a tough topic, and autonomy means differently. Autonomy for, say, an elderly individual who is towards the end of their life. Ideally, if we had advanced care planning and the ability for, and if we did talk about it and people could kind of make their own decisions in advance, it would take care of a lot of issues. And autonomy there means that the person you are at the peak of your life is the person who writes the narrative of that life. And if that narrative ends in a certain way, uh, that the speaker, the narrator writes it. I'm not sure if everybody gets it, but it means that towards the end of life, if somebody has dementia and they say enough, and they've said in advance enough, then you cannot really ask somebody with dementia what they want. So autonomy has to be separated out that way. The other part of autonomy being separated out, and this is where autonomy and equity run together, is when you are looking at somebody neuro with some kind of a chronic neurological condition. And I'll give you the example of something called spinal muscular atrophy. Right? Spinal muscular atrophy is like a paralyzing where the muscles waste away, and it can start off in very young children. Okay. Now, obviously, the child doesn't make these decisions. It's the parents who make these decisions. And where does it run into equity? Well, as you can imagine, the initial treatments that have come out are humongously expensive, like about a couple of crores a year. So, where does equity come here? Because, well, in the US, some people have been buying it, insurance has been paying, but Canada very early actually set up a fairly equitable mechanism to look at this whole question, and they actually said, no, our healthcare system is not going to pay for it. And they actually just cut that. But because it was a transparent and a clearly taken decision, it has been largely accepted. So autonomy without equity is a little tricky, because if you're poor and autonomous, what good is it? I'm not sure if I've answered everything, but I, I think you get my point.
Yes, loud and clear. Thank you, Roop. It is a difficult topic to really sort of disentangle and things like that. But I just felt that at least to get that conversation on the table, get people to think about it, I think it's absolutely essential. And what you just said, that autonomy and equity go hand in hand. One without the other is really not going to get us very far. So thank you very much, Roop, for that. I'm just going to go across now to Dr. Rajam Iyer. Rajam is a pulmonologist, like I said, and she actually wears two hats. One is of being a medical care provider and also one of being a family caregiver. And Rajam, what I want to ask you first is to just sort of tell us a little bit about your experience of palliative care. I know you keep saying in different forums that you're a newbie, but I have had a lot of experience directly and also through people who have been cared for by you. That you're a palliative care person, and I wouldn't ever debate that. What has the journey been like for you? Someone who's spent dedicated her life to pulmonology and then later in her career discovered palliative care. What has palliative care brought to your own practice?
Thank you so much, Smriti, and thank you, Pallium India, for giving me this chance. It's lovely to be with people like Harsh, yourself, Ashla, and Roop on this forum, and Dr. Rajgopal. Yes, I think I am very much a newbie in palliative care. I think it took me about 2 decades to be a trained respiratory physician, and I didn't have a single formal or structured session in compassion, empathy, communication, person-centered care, or in death and dying in those 2 years, in those 20 years of becoming a respiratory physician. And it's quite surprising now on hindsight to think that a profession so close to human suffering, so close to people with sickness all the time and death and dying, doesn't even prepare us for this. And my life actually changed in 2016 when I read the article written by Dr. Rajgopal in the Times of India about don't torture the dying, because it resonated very closely with how I had lost my first and best friend, my father. And on reading that is when I realized that, you know, as a medico, it was excruciating to think of the decision I had to take for my father and the way he passed away. And I struggled. I looked for affirmations from my colleagues, despite the 20 years of knowledge, despite the 20 years of contact system, supports, information. I still didn't know. I was grappling with how to decide and how to look after my father. And that's when, reading Dr. Rajgopal's article, I realized that I had done the right thing for him. And if a medico can suffer so much struggling with the patient at home like this, it kind of occurred to me that non-medicos must be suffering way more than this and struggling with what to do with their ill loved ones. And the only thing they can think of is rush them to hospitals, where doctors like myself never were trained in the concepts of palliative care. And this is where my journey took this detour into palliative care, and I landed up in Trivandrum and eventually have trained myself into a palliative care physician and realized the purpose of life had changed. And I started looking at patients differently. You know, when you look at patients with respiratory symptoms, we pass out medical school with a chip on our shoulder and feel we are the best thing that's happened to mankind. And we are here now to save lives. And then you realize, once you get to know the principles of palliative care, it's such a humbling experience and such a leveling experience, because you're not just with doctors, you're with physiotherapists, counselors, volunteers, social workers, and patients who've gone through this. And in respiratory medicine, like in any other specialty, we manage to cure only 1/3 of the conditions, probably infections. The other 2/3 are either controllable or incurable, focusing on the fact that most of the non-communicable diseases have a very prolonged symptom burden and a very high for a prolonged period of time. And that is where the focus of palliative care comes. All these patients of ours require the hand-holding. So if you see the latest WHO report, which has come out on the 9th of December, where it shows on the global health updates, 7 out of the 10 top killers are non-communicable health diseases like cardiac, dementia, stroke, diabetes, and chronic respiratory illnesses. So it clearly shows that our primary healthcare needs to be directed equitably and holistically to prevention of these, cure as well as care, because we can't cure diabetes, we can't cure dementia, we can only control them. So a bulk of our patients are affected by these, and we therefore realize a lot of Indians are in this bracket, and they really need palliative and supportive care. And unfortunately, because of the lack of training, there is a huge lack of understanding and misconception about palliative care. Also, because non-communicable diseases are not perceived as life-limiting and life-threatening. Very few people, when diagnosed a COPD or dementia, think they will be dying of it, because they will also be dying of it in 10, 15 years, unlike an emotional diagnosis of cancer, where the patient starts thinking of his clock ticking and that he's going to die. So is not perceived as life-limiting. Doctors need to realize that non-communicable diseases are a diagnosis for patients like falling off a chronic illness skyscraper. As the patient is falling in his floor by floor, it is the onus of physicians trained in the specialities to foresee and foretell how this journey is going to be and punctuate that journey with timely, sensitive communication, so that, when we talked about accessibility, affordability, and availability, we also need to think of appropriate medical treatment. In a country which has so much resource crunch, are we justified to put patients who do not need aggressive medical treatment, subject them to aggressive medical treatment, which is what I think Roop and me see very often. Patients can afford, patients have not discussed. Even if the patient is poor outcome for an intensive care, one bed is blocked for a patient who's probably going to lie there and languish for a month and probably die at the end of it. Money is not a problem for him, but that bed could have saved a younger person who could have been productive to his family and productive to the country. So it's also about the appropriateness of treatment. We are ending up doing a lot of medical futility, which is why the quality of death index in India, we are still the bottom 15 of the 80 countries surveyed. So I think palliative care, medical curriculum has to be integrated in the training of MBBS and MD. It has to be integrated in all specialities. Every physician needs to have the principles and concepts explained to hand over care to palliative care. It has to be a shared care between patient, primary physician, and palliative care in chronic illnesses, because I think we are ending up wasting the limited resources and not giving the patient appropriate dignity and respect that that patient deserves.
Absolutely, Rajam. Thank you for putting it so articulately. I think you've covered some of the critical aspects of this conversation that we're having, and you've quite beautifully highlighted how inappropriate interventions can actually, take us the other way in terms of equitable care, and also the appropriate utilization of resources, allocating resources appropriately, and I mean, I see this happen quite often. You raised two very important points that I want to also flag. One is about integrating palliative care into the curriculum, and I think I'm going to come to Harsh in a moment to also talk about that a little bit. But the other thing that you highlighted was the fact that the ICU setting, the lack of decisions, the lack of discussion around it, and also the fact that, very often I think what happens is that a super specialty, we talk about this a lot in palliative care, that they don't see beyond the organ, right? They don't like a renal specialist, a nephrologist will look at the kidney, a neurologist will look at the brain. We fail to see the personhood, and also the fact that that person exists within the ecosystem of a family, which exists within a social ecosystem. And what is the fallout? Roop talked about debt, but it also happens that people go into multi-generational debt, right? And that is completely inappropriate. And it is not just inappropriate; it's almost unethical that we would be subjecting people to that sort of inappropriate that sort of an inappropriate approach. Harsh, I'm just going to come across to you. You are a public health person, and we've now heard from Ashla as well as Roop and Rajam, who are both clinicians with a very compassionate and competent approach to providing healthcare. You have had a lot of experience before coming into palliative care. You've seen maternal and child health up close. You've traveled to different parts of the country. And now I just want to ask you, with your understanding of palliative care, where do you see universal health coverage and palliative care in the context of health systems? Where do you see the confluence of these two?
Thank you very much, Smriti. I think, and thank you, speakers. I think you guys have really given me the content, some pieces that I wanted to tie together with the universal health coverage. So before we talk about universal health coverage, let's remind ourselves what health means. WHO defines it as complete physical, mental, and social well-being, and not just the absence of disease and infirmity. Ashla very well reminded us with her own example that it's the person that needed to be seen, that we needed to go beyond the disease to the person for it to really be care. And I'm compelled to share a story that I just heard last night. A person told us about a young girl with cancer whom she just connected with in a hospital, trying to raise money for a prosthetic leg for that girl. And everyone hoped things would get better for her, but her next visit showed that her cancer had worsened and the doctors gave up. Now that's where cure ends, but does care end there? And it was just so beautiful the way this person described how that bond between the two of them developed, how the person kept providing them care. When verbal communication ceased, they were talking through text messages. When that girl could no longer speak, her sister was texting this person on her behalf. And now just imagine being in that condition where the medical system is giving up on you, your speech is giving up on you, your facilities are giving up on you, but there is care. It's there somewhere. Does healthcare not deserve that? By all definitions, it does. Now, in practice, how it pans out, I want to talk a little bit about that and tie it to universal health coverage. So healthcare should not just be the prevention and treatment of disease, but also address suffering. And this suffering go beyond the physical one. You look at people's social suffering. We talked about catastrophic health expenditure, their emotional well-being, their spiritual well-being, and so on. And with any life-limiting condition, so Rajam was talking about chronic diseases, our whole health system is so geared towards acute illnesses. What happens when you live with an illness? What happens? Does your care start getting diluted? Do such people not deserve enough health care? That keeps us from achieving the goals of universal health care. So, like I was saying, medical cures have their limits, but cure does not have to end at cure. Or how the ICMR, the Indian Council of Medical Research, laid it out. The duty of every healthcare provider is to mitigate suffering, to cure sometimes, to relieve often, and to comfort always. It's there that by practicing this, that I think we'll get closest to universal health coverage. And bearing this in mind, let's proceed to the synergy, like Smriti, you asked me, between UHC, universal health coverage, and palliative care. So I did spend some time yesterday going through the website and picking out definitions of the various sub-points of UHC and to align my thoughts for today. And after some time, I was struggling to distinguish UHC from palliative care. And I took the liberty of plucking some paragraphs out. The first one said, UHC means that all individuals and communities receive the health services they need without suffering financial hardship. And it includes the full spectrum of essential quality health services from health promotion, prevention, treatment, rehabilitation, and palliative care. So this addresses individuals, it addresses communities, it addresses financial hardship. All of them are components of palliative care, like we just heard. Also, one thing I want to mention, that palliative care does not exclude the other four components, the promotion, prevention, treatment, rehabilitation. For example, if we give timely care to someone living with some serious non-communicable disease, and we control the symptoms, their disease will not get worsened. So we are treating as well as we are preventing. A second paragraph I plucked was that UHC enables everyone to access services and addresses the most significant causes of disease and death, ensuring that quality of those services is good enough to improve the health of people who receive them. So this mentions everyone. It talks of inclusivity, a very central principle of palliative care. It talks of access, like the whole group has today. It talks of addressing. It doesn't say all of this has to be cured or all of this has to be prevented. It talks about all of this has to be addressed. These causes have to be addressed. And finally, it talks about quality and the significant cause of death and disease in palliative care language, we call it serious health-related suffering. Again, all components of palliative care. And in summing up, they did say that good health allows children to learn and adults to earn, help people escape from poverty, and provides the basis for long-term economic development. So here we're talking about like health doesn't end with not just with the organ, not just with the person, it's society and it's like socioeconomic. So the outcomes of total care that palliative care aims for, it ensures overall well-being of communities. And again, UHC and palliative care are very tightly aligned. The one significant difference between the two I discerned was that UHC addresses all essential health services, while palliative care focuses on serious health-related suffering. But the more I got into it, palliative care answered the issues that UHC laid out. So they have all these definitions, and then the website had issues of that the UHC addressed. The first issue was at least half of the world's population still do not have essential health services. So we talked of access a lot in this group. So within the what is missing in essential health services, I'll focus on India. Palliative care perhaps accounts for the greatest omission of an essential service in India. Out of 70 lakh people in India who die every year, almost 40 lakh need palliative care, and less than 1% are able to access it. And like Dr. Rajam pointed out, this inaccess is partly attributable to our health systems not keeping up with the spread of non-communicable diseases or NCDs. So earlier, these diseases were thought to be diseases of the rich, but they are increasingly affecting poor people due to unhealthy living conditions, poor nutrition, more high-risk behavior, and above all, less access to health services. And NCDs, Rajam gave a few examples, but includes heart and kidney diseases, cancer, blood pressure. And all of these things, if not attended to timely, they can cause immense suffering. And again, what is suffering? It's not just physical suffering. It can cause immense emotional suffering. It can cause immense social, financial, and spiritual pain to the patient. They can like start questioning, why me? Why has God done this to me? Their care providers can keep questioning, what wrong did we do? Why are we in this situation? And without palliative care, the current health system is, which is mostly meant for acute, not chronic illnesses, patients are not able to get appropriate answers and appropriate care. So I'm not saying cure, please be mindful, I'm saying care at every point. So patients with chronic diseases do need this regular support from both family, community, in addition to medical treatment, some answers that palliative care provides. Another issue that UHC laid out talked of health expenditure. So they actually gave the figures that around 12% of the world's population spends 10% of their household budget to pay for healthcare. So 12% of the world paying 10% of their expenditure to pay for healthcare. And what is the consequence? The global consequence is that around 100 million people are being pushed into extreme poverty. Extreme poverty, I think, is under $1.9 a day because they have to pay for healthcare. And like Smriti pointed out, a 2017 study showed that 55 million Indians annually get pushed below poverty line due to catastrophic health expenditure. Dr. Roop pointed out that 80% of Indians get private healthcare. So the public healthcare system is not giving the appropriate thing, and there is this whole chain of events which ends in poverty, and the poverty, as Smriti was mentioning, can be multi-generational. Many studies, I dug out some more studies, they've concluded that out-of-pocket expenses on treatment pushes millions into poverty. The proportion of houses experiencing this catastrophic experience, it has increased in the last 2 decades. And such expenditure was the highest among households with older people. So as I mentioned, without palliative care and community engagement, diseases can get aggravated. And a Medicare culture of super specialty technology, something that was touched upon, where you're like, okay, you have a kidney condition or you have a heart condition, let's just take it to its very limit and see how much can we fight against nature almost. And it keeps targeting the disease, even if it is at the cost of the patient. Like, what's happening to that person? Does that person want so much treatment? Is the person in pain? Are they able to bond with their family? Where are their wishes in all of this treatment? And the well-being of the patient and family, is it considered in the super specialty culture? And this, I'm borrowing Atul Gawande's vocabulary, this over-diagnosis, this over-treatment, and this consequent catastrophic health expenditure, it's highly concentrated in the end of life. Palliative care addresses all of this. It gives timely, compassionate treatment, which prevents both aggravation of disease, and aggravation of disease in such conditions can also lead to irrational decisions. We have therapies for that. We have methods, proven healthcare methods for that. So appropriate end of life care, it not only offers dignity, but it also avoids unreasonable expenditure. When the whole environment is encouraging, do whatever is needed, like for the Sindhi lady, that it had other reasons as well that Dr. Roop mentioned. So I'll sum up with 2 points that affirm that palliative care is an approach rather than a branch of medicine. This is no Lancet. These are my words, so do not quote them. But palliative care puts the patient and family at the center of care. So it doesn't put the disease that, it's not like a cancer walking into a clinic or a kidney walking into a clinic. It is a person who has certain socioeconomic circumstances and caregivers who are here for care. It looks at the person as a whole. It takes care of their physical, emotional, social, spiritual needs of patient and family. The caregiver is also deserving of care. And it is not only for end of life, but it is often conflated with it because it becomes very important at that time when people spend a lot of money or when people do not know what to do when a condition arises, and the environment encourages this overdiagnosis and overtreatment. So while one can specialize in palliative care, one doesn't need to be a specialist to practice it. What one needs is compassion and humanity. And Dr. Rajam gave her own example that she's a pulmonologist, but she's a palliative care physician. Roop here is a neurologist, but you do practice palliative care. Any healthcare provider can integrate this in their work. And I'm also talking this from experience. We are currently working with the government for our frontline force, for people who are maybe or maybe not past class 8, to practice palliative care in our rural villages. Second point was that, so my larger point was that palliative care is an approach rather than a branch. That palliative care can be provided at home, it can be provided at the community, and it can also be provided at primary, secondary, tertiary healthcare centers. So what sets it apart, what I started with, is the focus on care, the care beyond cure, and anyone at any level can practice by compassionately attending to any patient and their loved ones, focusing on the people, not the disease. This flexibility also becomes a responsibility for most of us. If we are not living with a serious health related condition, we are the community who can come together and do something for those around us. The healthcare system, Dr. Roop started with, we are at a certain level of evolution. It will come around to acknowledging this and to appreciating. We don't need to wait for that. And in doing so, by being the community that brings compassion into healthcare, we can bridge the issues laid down by universal healthcare and provide quality services to people when and where they need it. Again, going back to, as I finish, the initial end goal of universal health coverage that they mentioned, that good health allows children to learn, adults to earn, and helps people escape from poverty, and provides the basis for long-term economic development. So India's health system has recently, and by recently I mean till today they were training the frontline workers, started taking concrete steps to integrate palliative care into primary health care. And one hopes this will continue with desired commitment and quality to meet the goals of UHC, and it will translate into long-term economic development for the country. So, Smriti, that was a long answer to a short question, but I hope I've talked of the synergy between the two. Dr. Roop.
You have. I'm just going to pick up a couple of threads from this incredible fabric that you just wove. You've given us a snapshot of, which is not easy to give, but I think you did it wonderfully, Harsh. There are a couple of things that you said that stood out for me particularly. And I can see some discussion in the chat box, which sort of relates to that. One is, it seems to me that we're almost like a cat chasing its own tail. We talk about palliative care relieving serious health-related suffering on one hand. And then on the other hand, it seems to me that a system that inflicts poverty, inflicts suffering, something needs to change there, right? And it's like I said, it's a systemic change at a massive level. Someone had mentioned in the chat box that, okay, like for example, schemes are available, but nobody knows about it. one of the beautiful things about palliative care is its interdisciplinary approach, that it makes place and space for a social worker to be part of the team, who interacts with the family as much as the specialist, as the doctor or the nurse. And it is the duty and the role of the medical social worker then to figure out what are the gaps that are adding to the suffering of the family on an economic level, on a socio-economic level, right? And that is a perspective that palliative care brings. And we try and do away with the hierarchy, the implicit hierarchy that exists between the doctor, the nurse, the social worker. You know, everybody has a role. There's a lot of respect between different clinicians, the interdisciplinary team. And we've talked about this several times, that palliative care looks at it as total pain. And when we say total pain, we talk about not just physical pain, we also talk about the pain of the poverty that poverty inflicts on them. The fact that children are pulled out of school because that money has to be reallocated towards treatment, which in a lot of cases is futile, right? So the interdisciplinary approach really also looks into that last mile where people are able to access schemes that are available. Then again, we're talking about access, availability, and bridging that access and availability gap. The second thing that I wanted to bring up is, how do we affect change at such a massive level? And Rajam and Roop, you have, you've come into this with, wanting to integrate palliative care into your approaches. I know Roop is really sort of making a case for neuro-palliative care in India, and he's roping in experts from around the world. And it's a new field, but it's such a vital field. But there is that will that the two of you have to integrate it into your approach. But for a lot of people, it's a lot of unlearning, right? And I always think that unlearning is far more difficult than learning something earlier on. So questions have been raised about how do we make palliative care part of UHC? How does UHC really sort of address all these issues? And really the answer lies in education, does it not? So integrating it into the medical curriculum. And in 2019, in March, the Medical Council of India introduced end-of-life care, elements of end-of-life care, pain management, and attitude, ethics, communication. I just want to hear from you, Roop, because I know you're going to drop off this call in a few minutes. What are your thoughts about that level of integration, not just at the MBBS undergraduate level, but also at the postgrad level? And how important do you think that is in really bridging the gap?
Okay, so a couple of parts to it. One of it is, of course, stuff that needs to be done at the MBBS level, and that's something that can only be implemented from the top down. And that is happening. The 8Com module is out. Now we can complain that where are the teachers who are going to teach 8Com? But we have to begin somewhere, and I guess over a period of time, standards will improve, more and more people will get it. So from the top down, it's been accepted that that is something that has to be done. What about from the bottom up? What about us palliative care people expanding our reach? What about standardizing our curricula? What about making sure that we offer a single level of certification courses to anybody who wants to take it? Now, for that, I think this is something that we in palliative care need to get together and set up standards and say anybody who sorry, just give me a minute. Sorry, Siri just woke up, so and interrupted what I was saying. Okay, so what I think is that that's something that palliative care now needs to get its act together and offer palliative care education that is standardized, easily available to everyone. I'm not saying doctors. I think we are over-focused on doctors. Why can't we offer counselors courses across the world? Why can't we offer courses for social workers? I think all of that is not very difficult to do. And at least one thing has happened in this pandemic. All of us have gotten used to the idea that so much of this can be done online. And palliative care is not like intensive care or one of those procedural specialties where you actually have to pick up things and learn how to do them. No, so much of it is all in the mind. And as you start doing it, it can be taught. I think we all need to take that up seriously because
Right.
it's both demand and supply. India is low demand for palliative care and low supply for palliative care. We have just no capacity in palliative. So although Harsh said only 1% get it, but that is all the palliative care people in the country working full stretch. So how are you going to give more than 1%? You can't.
Thank you, Roop.
So I've done my ranting. I'm going to have to jump off now.
It wasn't I think these are the honest conversations that need to be had. Thank you, Roop. Thank you for making the time to be here today. And we really appreciate your insights. I'm just going to come back
Thanks everybody for having me. I'm jumping off.
Thank you, Roop. So that's a very important point. One is that I think we also need to, while we have this clarion call for palliative care and universal health coverage, I think it is we always need to introspect and reflect on what we have done and what we are doing. As a person trained in psychology, even now, I don't know who's teaching, therapy in palliative care. I mean, we go and we learn what we can from different mentors and workshops and things like that, but there is no standardized curriculum. And now we're doing a virtual program for non-medical professionals who are very keen to be part of the palliative care movement, but earlier there was just no training available to them. There have been comments in the chat box also that there is a stark difference between reality and need. And we cannot do this without the government. We absolutely agree that this cannot be done without the government. And while it's easy to take pot shots at the healthcare system, I think it is also really important to remember that it is, rather than a confrontational approach, what we really need is a collaborative one. We cannot do this without our doctors. We cannot do it without our nurses, and we certainly cannot do it without our government. So it's about us also bridging the gap between ourselves as much as it is between different systems. Roop actually triggered something, that's a good segue into what I wanted to just address with the three of you before we really go into the discussion and take questions from the audience. And that is, while we've talked about universal health coverage, we've talked about it in a way of, what is ideal. And very often I hear this from people that, what universal health coverage prescribes is so utopian. It's so utopian, right? So how does it really work? And is it really realistic? But my personal opinion is that, so far we've been so far behind. We're way below the baseline of 0. So any steps in that direction is a step in the right direction. And while all of this was being, we were trying to wrap our heads around the Astana Declaration and what it means that palliative care has now been listed, along came the pandemic. And so I just want to focus on that a little bit now that we're in the thick of it. And, we've seen the changes. It's not like the first few months where we were still trying to figure out how we're going to recalibrate. We are now in a place where we have, at least to a certain extent, reorganized our services. We understand what is required of us. It has also brought palliative care to the forefront in many ways, right? And palliative care has now emerged as one of the most effective responses in many ways to the tragedy that is unfolding around the world. So I'm just going to come back to you, Harsh, first, and then, go back to this. What is your take on this pandemic coming in as, a curveball? And how has that affected this whole synergy that you've been talking about? And what does the picture look like to you now?
Thanks, Smriti. Smriti, you brought in two things that, we are not at a baseline, we are trying to reach the baseline. And then you talked of the pandemic. And I think the response to both the things is similar. Where do we need to start? Obviously, we need to work with the government. That's how health becomes public health. We need to, but that doesn't mean we have to keep waiting for the government to enact the ideal. in parts of India, especially Kerala, we have seen communities come together, and it becomes the bridge between the individuals and the health system. There is a compassionate community watching out for you, and you do get you're seen as an individual, you are acknowledged, and you do get the care when and where you need it. And these are not medical professionals, and be it doctors at specialist facilities, they can integrate it in their practice. They can, a lot of things that Dr. Rajam mentioned, compassionate communication, or how do you view the person in whatever their specialty is, they can integrate that. Some person maybe who works in policy circles, they can implement it even if it is at a sub-district level. And as individuals, what I was mentioning in my, when I was giving my remarks, that we can look around us and be conscious and compassionate with people living with serious health conditions around us. Speaking of which, the pandemic makes these people, it's not, you don't have to go looking out for them. They are, if not within our family, they are all around us. And it's really laid bare the gap in our health system, where the trust between communities and between the health system is cracking, because it wasn't built on compassion. It was built based on a disease-specific care. So if this compassionate communication, this trust between individuals and their providers existed, it would translate into trust between communities and between health systems, and we would be in a more resilient position to respond to this. Speaking of doctors alone, although Dr. Rajam probably is the better person to answer, but it's common knowledge that no one taught you to, see so much death and suffering, to like have so many difficult conversations, not just to attend to your patients and to their families, but also to attend to yourselves. The daily toll that this takes emotionally on doctors, where's the education for that? That you are there was so much esoteric moral conversation about your time has come and it's a time for duty, but where is their well-being in amid all of this? Had palliative care, its principles, its compassionate communication, care for yourself, for patients, families, been integrated, and there was even the knowledge that such a thing exists, we would be a stronger, more resilient system. So there is someone for everyone to do. You don't have to be a specialist. You can just espouse compassion and humanity. And the need for it, I think, is very heartfelt, as laid bare by this pandemic. I'll stop there.
Thank you, Harsh. Thank you. A very compassionate view also, not just an insightful one. And you're right, it has laid bare a lot of the gaps. And one of the things that we witnessed in Kerala was, at least in Trivandrum, right across the state, is how eager the community was to get involved. Right. And some of you know this, that when the initial part of the lockdown, we found that elderly people living alone, people who were confined to wheelchairs into their beds and did not really have the support network, they were really struggling. And it wasn't just about COVID. It was, manageable conditions like diabetes, which could be managed, were spiraling into life-threatening conditions because people didn't have access to the basic medicines that they needed. And at a time like that, when we put out the call in a newspaper, we had 87 volunteers sign up in 24 hours. And they became the people who bridged the gap. And, it was not just about getting the medicines across to these people who were isolated or who were having difficulties accessing healthcare. It was also lab technicians, people who went and drew blood and made sure that, those investigations happen timely and all of that. So there is that whole social capital that we need to think about, and which is a huge part of what palliative care prescribes. And I think we would all do well to sort of look at those strengths in our own communities. It does not exactly have to be the Kerala model. It has to be the model that is best suited to the community that you belong to and the state that you belong to. I'm just going to come across to Ashla. Ashla, I'm going to ask you a question. And you know what my question is going to be. As somebody who has been living in a healthcare facility, and as someone who's been a care recipient and a strong advocate for access, I'm going to ask you, what changed for you during the pandemic?
Thank you, Smriti. and a very easy question to answer. That for me personally and in terms of my freedom, nothing. Like absolutely nothing changed. Like I was kind of, I don't know whether it's the right thing to do or right thing to say, but I was kind of laughing that people were. So I understood their like suffering. I acknowledged that, but still, like there were a lot of us who were already going through all these kind of things, and nobody noticed it at any point of time. And all of a sudden, it was a issue for everyone, and it got the like people started noticing it. There are a lot of emotional issues when you are confined home. You have like all those issues were coming out in newspapers and people were talking about it. But like people like me, there were a lot of people already there for like so many years. So were confined home, confined to a room, and people like me, nothing changed, like at least in terms of freedom. Yeah, of course, uh, as a person who was in palliative care, I've seen a lot of people suffering in other ways, like they did not have access to proper medications, and they did not, the paid caregivers could not reach their home, so they couldn't get their daily care, and then they were in hospitals wherein allowing caregivers, and then there weren't enough people to care for people when they get COVID. I know of a person who got COVID, and then like when he was discharged from the home, COVID was treated and cured, but then he got more physical issues, and then he went into hospital with COVID. So all those kind of things happened, and it was very difficult for people with disabilities, even in Kerala, and more than that in outside of Kerala, because in Kerala at least we have got all this community help, and there were a lot of help available. Still people suffered, but still it was much more in other places of India. So it was like personally it was so like difficult for me to hear all those kind of stories when people said that they weren't like people were not given food when there was a scarcity of food in the family because they are disabled and they can't go to the kitchen and feed themselves. So they were deprived of that, and they were never given some kind of a privacy to be, and then all those meager income which they were getting from their whatever work they could do, it stopped, and then that changed the mentality of the family members, and they weren't considered human anymore. So there were a lot of stories, and it was very difficult to hear for me all those stories. But yeah, like it is two different things. One side for health access, it costs so many things changed, but when it comes to like freedom and social life, for me personally, nothing changed. And I know of a lot of people for whom nothing changed, or it was the same for many years. Thank you, Smriti.
Thank you, Ashla. And thank you for showing us that. So many of us take our freedom and our ability, independence. So we take it for granted. And I think what you just said to us, that many people have been living with these constraints and these restrictions for so long, and they've just been invisible. The pandemic has made so many things visible to us, and so that's the other side of the story as well. Thank you, Ashla, so much. I see a sort of conversation going on in the chat box about and about whether it is you're born with it or whether it can be cultivated. And I just think that this is again not an expert opinion, just the opinion of somebody who's been involved in palliative care. That I think all of these things, all of these traits, it's like when you work out physically and you go to the gym and you concentrate on a particular muscle group, it's that muscle group that becomes stronger. Similarly, I think what you practice gets stronger. I don't think anyone is born devoid of compassion. I don't think that it can be, it's something that if you're not born with it, then you don't have half a chance of ever cultivating it. We're all born with it. It's about how much we practice it that eventually makes it our default setting. And we can then bring it into our approach, no matter what it is that we are working on. It doesn't just necessarily mean healthcare. I'm just going to come across finally back to you, Rajam. And what I want to ask you is, you talked about the fact that you're a caregiver to your elderly mum. And while we're talking about, people who are already marginalized, even before the pandemic hit, what universal health coverage means for people of privilege, what it means for people without privilege, people who are relegated to the very peripheries of society. And then there are those that we just don't want to look at, people who are substance users, people who are, not socially, also there's a moral angle to how we perceive them and things. But in this right now, I just want to ask you, what was it like to be the caregiver to an elderly lady, to an elderly mum in an apartment in Bombay, in a city that has so many things going for it, right? And what was the pandemic like for you? What was the experience of the pandemic? Because you're a respiratory respiratory medicine doctor, and I know for a fact that you were fielding hundreds of calls a day while looking after your mom. You were nursing people back to health. You were guiding them back to health. I just want to ask you a little bit about that.
So I think this pandemic has made loss very overt. It's like Ashla said, what Ashla said really touched me, that life didn't change for her. But I think for people who were, there was a loss of freedom, there was a loss of livelihood, there was a loss of jobs, and there was a loss, this restricted movements. And when the pandemic hit, actually, at the same time, my mother also took unwell. And I think despite being a medical profession, the fact that I couldn't go take her to a hospital for investigations, I had to rely on people calling me on the phone and telling me about what I could do for her back. And despite the fact that I had all the information, just the sheer helplessness of not being able to relieve her pain and seeing her suffer, seeing her not, get access to the right spine doctor because, all the electives had stopped, all the outpatient clinics had stopped. So the fact that I could pick up the phone and speak to my friends and get the necessary prescription, but there are lots of those people who do not have medical, fraternity in their house, or do not have medical help at a phone call. So it really brought me into the idea into sharp focus, that what happens to all those people, which is the reason, Smriti, that I therefore make it a point to at least try and help those people whom I'm not even able to see. Because I know what a difference it made to me when my friends picked up my phone or messaged me back at 2 a.m. saying, give this medication if mom is feeling like this, or do this if she's feeling. And I know what a relief it brings to me. Because when it comes to your own, your rationality is out of the window. You feel helpless when you see a loved one suffering. And this is exactly what happens to everybody. I don't think education or bank balance has anything to do with simple raw emotions. It makes a difference when somebody is asked for help and you manage to give even a one word answer saying yes, okay, or do this, or give this tablet. It makes a world of difference to them. And like Roop said, we also realize that it's better to have this telecommunication or digital medicine than nothing at all. I know I couldn't take my mom at 82 to the doctor or to get an MRI done the day the lockdown started. I know how difficult it was. I didn't have a driver, I didn't have a maid. Accessibility of taking even an 82-year-old who's a little on the heavier side on a wheelchair, to push it, to drive, it's all very complex. I completely understand where Ashla comes from. So I think it helps to be connected even by that. And it was immense relief that there were people ready to help. The other thing that the pandemic showed me, like you said, as a pulmonologist, is the sheer lack of preparation that we pulmonologists were. The overwhelming numbers, the fact that even if it was only 5% of people with severe illness, we are not prepared with that kind of infrastructure. We didn't have the ICUs, we didn't have the ventilators, the moral distress of whom to put on the ventilator. Who decides that? Is it the age? Is it the fact that the patient is more affording? Is it the fact that the patient came before another 40-year-old? It was a time where it was, where I saw my friends and colleagues sought out to me to say, please come and help this situation. There is this 85-year-old with so many comorbidities. She is not going to make it. We need you to come and talk to the family. So there is that kind of suffering. There was another lady whom I had to go and tell her that she had lost two of her young sons aged 40 and 50 while she was recovering from COVID. these kind of devastating suffering, it was hard to see, because it was not just, it just didn't end. You see, this whole problem of the pandemic is the fact that it is going to be here. It's an ongoing thing. And so many people were suffering all at the same time. So as a doctor, my heart went out to those families who were being quarantined, who were being isolated. They were suffering alone. They were dying alone. Friends couldn't come to see their parents' funerals or last time. There was no hug. There was no bidding farewell. So that's that kind of suffering. And then, of course, the non-COVID people were also suffering. We suddenly didn't have heart attacks coming to the hospital. We didn't have strokes. Probably they were all dying at home. So there's been a tsunami of suffering at all levels: emotional, physical, psychological. And I think I myself realized that even with a simple thing, I mean, I call it simple now on hindsight because she's better, but those 6 weeks were excruciating for me. Even as a doctor, I needed help to be constantly reassured that I was doing the right thing at home. So I can imagine the amount of suffering that people world over have gone through, and especially in India, where, doctors are still not uh, that trained to do telemedicine, or effectively so. And probably we really need to train them in compassionate listening and being able to at least hear, like everybody has been talking of, addressing and acknowledging. We might not have solutions, but I think a lot of it, the sharing and the acknowledging of symptoms itself, relieves the person on the other side of the phone or of the computer screen. So I think that is important. At least be there for them. Like people were there for me, I really feel the least I could do is be there for my patients.
Thank you, Rajam. The world is a better place for having a doctor like you in it. And thank you so much. You have highlighted something that needs to be discussed. I'm just going to sort of mention it before I just move on to the next segment. And that is, in palliative care, we talk about invisible patients. Who is invisible? People who access healthcare become visible. But what about the millions of people who are not able to show up at a hospital? Who addresses their suffering? And we see this. We see a gender inequity in accessing healthcare. Women access healthcare far less than men do. And when they do access it, the quality of treatment sometimes differs. Very often it differs. Most of the time, caregivers, 80% of caregivers globally are women. Then we have people with disabilities who also have access issues. And of course, the pandemic has really sort of widened that whole gap. And one cohort that we don't talk about that much, who is really suffering right now, are the healthcare providers. The trauma that the healthcare system is undergoing across the world, the trauma that healthcare providers are experiencing by not having the words to have those conversations with families, by not being able to deal with their own vicarious secondary trauma that they experience. We have, which we've talked about before, that there is a pandemic of mental health coming. Mental health issues coming. There's a whole other pandemic well in the mix. And that is something for us to also think about, but we don't really have the time for that right now. I'm just going to invite Dr. Raj to come and be part of this conversation. I see that in the chat box, Dr. Raj, there's a very important question. And while we're on the topic of marginalized and very vulnerable people, someone raised the topic of chronic pain. We talk about pain a lot in palliative care. Now, I just want to talk a little bit about the fact that there are millions of people living with chronic pain conditions. And for whatever reason, they are not really, beyond a certain point, they are not given appropriate care. And that was a question that came up in the chat box, Dr. Raj. Can I please invite you to address that?
Smriti, thank you. And Smriti and faculty, congratulations on this excellent discussion. The chat box is full of compliments to you. Several people have asked for the recording and the whole procedure. I hope you will be able to do it. And specifically, thank you for pointing out the question from my friend Anubha Mahajan, who works in Delhi, runs an NGO for people with chronic pain. She lives with chronic pain. And as long as we have been in palliative care, which is about 3 decades, My colleagues and I have always treated people with pain. And because palliative care is very often associated with pain, people do come to us. So, and I see how much of injustice the global palliative care scene is doing by not including them in the domain of palliative care. Even the Lancet Commission list of conditions necessitating, including serious health-related suffering, it's not included. They walk about, they go to work, they are living a life of pain. People with non-specific pain conditions, people with low back pain that cannot be treated surgically. Oh, if it can be treated surgically, we are all very much interested. But we medical professionals hate to say we don't know how to do this. And there, thank you, Rajam. Certainly, being there is so important. Being there for them, because if palliative care providers do not see them, nobody will. Oh, a few chronic pain centers exist in some major metropolitan cities. Thank you very much. All respect to them. But to reach out to the people, to be there as Rajam Iyer asks us to be, we need to be working with them. I'm very glad that there have been initiatives by Dr. Rakhavendra and some others who have tried to amalgamate the two, with not with the much success that I've seen so far, but everything has a beginning. People with chronic pain live with physical pain, huge social pain, because their struggle to overcome the pain and live with the pain affects their behavior at home. It causes enormous emotional suffering and spiritual pain, and many of them keep asking, why am I alive and why is this happening to me? So thank you, Smriti, for the question. If we are not too afraid, that's the reason. We don't see them because fear overcomes us. Oh God, how will I handle this? But if we overcome our own fear, we will see that we have to include them in the fold of palliative care.
Thank you, Dr. Raj. Compassionate and emphatic words as always. Um, we have just a few more minutes, and I just want to share with everybody a little experience. Dr. Raj and I once got on a flight from Delhi to Trivandrum, and as you can imagine, it's a long flight. It's not. It's one of the longer flights, and as the flight took off, we decided to sit down and make a list of all the people, of all the communities that are not that are vulnerable and that are marginalized. So we started having this discussion. I started making notes, and of course, there were the elderly, there were women, there were children, all of that. And then we said, okay, let's put it down: socially marginalized, medically marginalized, culturally marginalized. And let me tell you, when we landed in Trivandrum 2.5 hours later, that list was still not complete. So when we talk about universal health coverage, I think it's very, very, very essential for us to remember that universal health coverage is not just health coverage for us, those of us who have the privilege of being part of these discussions, who have a seat at the table, but for all of those people who, I will not say they're voiceless. Everybody has a voice. It's just that they're not given the platform. And every single one on this call today is an advocate. And for having been part of this discussion, for asking these really, really important questions, I hope that you take back with you some of the things that we've been discussing in your own settings. It doesn't have to be, in a big way. It can start in your own home. And let's keep an eye out for those who are made invisible by the system and who are not heard, deliberately silenced, or preferably unheard. And Dr. Raj, I just wanted to, before we end, invite you to talk about the white paper that we are launching this month.
But Smriti, with your permission, there have been, unfortunately, we have not been able to address it. There have been very many, very relevant issues brought up in the chat box.
Sure.
One of the audience, that was, I have 4 minutes. Okay. So, Sri Keshav Deshraju who was the former Principal Secretary Health of Government of India, and who, with one stroke of his pen, created the National Program for Palliative Care of India, and who we are proud to say is now a trustee of Palliative India. He had to leave in between, but he mentioned education. What's the use of all this if medical students do not get educated? And then Poonam came out with a different question that's also related. Ladies and gentlemen, so many good things are happening at the level of the government also. 2010, palliative care included as a medical specialty by Medical Council of India. 2012, National Program for Palliative Care started by Government of India. 2014, Narcotic Drugs and Psychotropic Substances Act amended. 2017, many aspects of palliative care included undergraduate medical education. From 2019, medical students are supposed to learn most of palliative care. So many things are happening, but who knows about it? It's for us. That question came up. Bhavana asked, why are we not engaging the larger community? Others, philosophers, everybody. We are holding all this within our tight group. We need to open up, engage the common person. And particularly in terms of people with disability that Ashla was talking about. Gina, will you please put up the link in the chat box? Palliative India, led by Ashla and many others, Palliative India has brought out a white paper today. I have a request to you, all of you. Gina has put it upon the chat box. The link is there. Please look at the white paper, which asks for inclusion of disabilities as an entity that deserves palliative care. On the international scene, it is not so. In Kerala, it is so. People with serious, significant disabilities like Ashla live with serious health-related suffering. They overcome it because of their willpower, provided we, the medical system, can do our bit. Do please see the white paper and share it, and let us know what you think about it. People with major disabilities, people in prisons, people with chronic pains, people with dangerous diseases like dangerous to us, like multiple drug-resistant tuberculosis. So many marginalized people deserve our care if only we overcome our fear and are able to engage them. Thank you, Smriti. Last few seconds left.
Thank you. Thank you so much. I'm amazed at our timekeeping, to be honest. It's exactly 6:59 and we are on time. So thank you so much, Harsh. Thank you, Ashla. Thank you, Rajam, for your extremely compassionate insights. I cannot overstate that. It's one thing to be an expert in your field, but it's another to articulate it with compassion. And I think all of you made such incredible points today. I was trying very hard to write down some quotes, but I know somebody else has also documented it, so it's not just on me. And Dr. Raj, thank you for those invaluable final words, and for making sure that those comments didn't become invisible, because I missed them. So thank you so much, and thank you everybody who joined us today. I think this recording will be available later. And have a wonderful weekend. Thank you.
Thank you, and stay safe, all of you.
Thank you.